So we're going to be going through metabolic bone disorders. This is the overview of, hopefully it'll take around an hour, I'm thinking. Maybe a little bit longer, but I'm not sure yet. So just going to start off with a quick quiz, try and get some, sort of generate some ideas around what we might be going through. And then we'll go through some basic anatomy, physiology of bone, look at vitamin D and parathyroid, the parathyroid gland. And then we'll go through some cases and then a few questions at the end as well. Okay. I'll just go through it. Do you think it's produced in the liver, kidney, skin, or the bone? And as you can see from the side, it's produced in the skin. We'll go through these things in a minute. Basically, just to start, it's further hydroxylated at the kidney and the liver, but obviously that's a misconception that it's produced there. The bone doesn't produce vitamin D. So the second question is, what the most common cause of hypoparathyroidism is? Do you think that it's DiGeorge syndrome, a previous thyroid surgery, radioiodine therapy, or steroids? Again, you can see the answers on the side, but basically most of the time it's caused by previous thyroid surgery. So it's an important thing to ask about in histories and things. Around 9% of people that have a total thyroidectomy will have hypoparathyroidism afterwards. So, okay, then we're going to be discussing bisphosphonates a little bit when we talk about the management of some of these conditions we're covering. Which of these isn't a bisphosphonate? So, alendronic acid, zoledronic acid, rosendronate are all bisphosphonates. Denosumab is a monoclonal antibody that's used to block osteoclast activity. It's a RANKL inhibitor. We'll talk about that a little bit in a bit. Okay. What type of score do you get from a DEXA scan? This is just pretty basic, but you get a T-score. The others are just made up. We'll be just discussing DEXA scans a little bit. But just start thinking about when we use DEXA scans, what it can show. And then parathyroid hormone does reduce serum phosphate levels. We'll be discussing a little bit about sort of homeostasis of calcium and phosphonate and PTH and how that all links in a little bit. Okay. Right, I'll go through my PowerPoint. So that didn't go as quite as planned, but well. Okay, so just basic bone anatomy and physiology, going back to first and second year. You've got long bones and flat bones. You've got cortical bones, which is sort of the hard outer of bone. It has those haversian systems, which are like the circular things with the blood vessels that run through the middle of them. And it's dense, hard envelope. Whereas the trabeculum is the center of bones. It's the meshwork that has the bone marrow within it. And then you have your three cell types in the bone: osteoclasts, which obviously do bone resorption, osteoblasts for bone formation, and then osteocytes, which differentiate from osteoblasts, and they're sort of the normal cell within bone. They produce RANKL, which we'll discuss a little bit in a bit. Okay. So there are some close links with lots of signaling sorts of hormones and receptors, such as PTH, estrogen. Another quick question I can ask. So ALP, we'll be discussing sort of serum levels of sort of markers, things that we'll look at investigations wise. Can you think about where ALP is produced in the body? Obviously one of them is the bone, but often people will discuss ALP results with regards to some of the conditions we talk about. It's just important to remember that ALP is also produced in places like the liver, kidneys, other places, but what it is used for in the bone is sort of bone mineralization. Okay. So Bone remodeling is regulated by parathyroid hormone, testosterone, estrogen. We'll discuss that a bit further later on. Parathyroid hormone increases bone resorption and formation, but obviously when we think about the parathyroid hormone and its sort of intention, is to increase serum calcium levels. And so what it does is it increases bone resorption more, and what that does is it mobilizes calcium within the body, and it allows the serum the concentration of serum calcium to increase. So 99% of your body's calcium is stored within the bone. PTH allows some of that to be released into the blood. Estrogen, testosterone decrease bone resorption and increase bone formation. Problems to do with a lack of estrogen we'll discuss later on. Glucocorticoids, as it says there, increases bone resorption and greatly decreases bone formation. Both of these are obviously bad for bones over a longer period of time. And so what you'll find is that glucocorticoid use, high dose and chronic glucocorticoid use, is a strong risk factor for certain bone conditions. There's an example of some Haversian canals here, and that's a long bone there. Okay. Right. Okay, think about, so no, just go for it. Parathyroid gland, obviously it's found on the posterior of the thyroid gland. There are 4 of them. They're all very small glands, around 30 milligrams each, apparently. But interestingly, they have one of the highest blood supplies per the mass and size of them in the body. And so what I learned when I was at the Royal is that when people have had surgery on the parathyroid glands, because of the enclosed space at the neck and the rich blood supply it has, for example, they leave stitching untied at the end, so that if there is a hematoma that's developing, they can pull that out and evacuate the area, because obviously there's some quite important anatomical things around the area, such as obviously your venous supply of the brain, and which will be compressed first. So that's what they're concerned about there. So I've got a little diagram of the parathyroid hormone sort of feedback loop next, but just briefly we'll discuss it. So it regulates calcium and phosphate homeostasis and vitamin D metabolism. It acts primarily on the renal tubules and promotes resorption of calcium from reabsorption at the renal tubules, and then also acts on the skeleton to increase that osteoclastic bone resorption, to mobilize calcium to increase serum concentrate levels. So, and at the bottom obviously it has, so what you'll find is that PTH, vitamin D, calcium, phosphate, they're all very much interlinked, and you'll see that here. So calcium level, if I'm going too fast, by the way, just send me a message in chat. Yeah, and I'll answer any questions you have at the time as well. So your chief cells in your parathyroid gland detect your calcium levels. If that's reduced, it then promotes PTH secretion. That then acts on what we've talked about. So it acts on the bone to increase osteoclastic activity, renal tubules to promote calcium reabsorption, and that also decreases phosphate reabsorption at the same time. It also then promotes vitamin D hydroxylation, which has its own action on calcium levels. But all in all, that then increases your serum calcium up to a point where then it's normalized, and your parathyroid gland then no longer secretes that PTH. So vitamin D, so it's mostly generated in the skin. It's converted by that enzyme there, 7-dehydrocholesterol. What you'll find is that during the winter, Europeans like ourselves, we are often have a vitamin D deficiency. We rely on stores from the summer, and most of our vitamin D actually comes from UV light. So 70% from UV light and 30% from diet. So diets such as fish, milk, other dairy products, that's where it mostly comes from. And then there's a sort of that process of production and then hydroxylation for it to become its active form. Just a little point at the end there, it's in the elderly, vitamin D levels are low because of sort of that increased sedentary lifestyle, lack of exposure to the sun, and also less efficient skin conversion. And then just in terms of names, these always confuse me a little bit. They all sound very similar, but basically cholecalciferol is just active vitamin D3, which is also your 1,25 hydroxy vitamin D. So that's the last stage of hydroxylation. Just before that, you have calcidiol, which is 25 hydroxy vitamin D, and that's also called vitamin D2 sometimes. And then the synthetic names of those are ergocalciferol, which is synthetic vitamin D2, and then calcitriol is synthetic active vitamin D3. These can be used at different points in the management of certain conditions. Okay, so it's just a little diagram of. So a good question. So Danny's just asked, how do people with kidney disease convert vitamin D into its active form? So as we'll touch on later, they have an issue with this. Vitamin D2 does have some, it is slightly effective. It's just not as effective as vitamin D3. And so that obviously might you think, what about people with liver diseases? And both of these people can, both patients with those sorts of problems can find themselves having vitamin D deficiencies. And so that's where drugs like the synthetic ones can come in place and help treat those and any conditions that may arise from them. So here's just a small diagram to just try and give you an example of what vitamin D does. Obviously the main thing is at the end is that it increases intestinal absorption of calcium, and that's its main action really. It has a small amount of action on the bone remodeling because of the homeostasis of the calcium and phosphate that it has, which is needed for bone modeling. But without vitamin D, calcium is very poorly absorbed by the intestine. And so it's really important that you have that active vitamin D to encourage that absorption. That absorption can also cause some of the issues that we're going to talk about. Okay, so case one. A 59-year-old female presents to A&E with abdominal pain and fatigue. So it's quite a general presentation. Can you just type in the chat some ideas about what you might be asking with this patient? Have a think about sort of. Yeah, good, Socrates, but two of you said Socrates. You're definitely going to be thinking about sort of that pain in general. Obviously, there's a huge number of problems that can be caused by abdominal pain. You know, or your actual gastrointestinal issues and things like that. This is a metabolic bone disorder teaching session, so we're not going to be going through those, but this is basically just to try and show you that bone issues can have other sorts of presentations. Yeah, you're going to be looking at the past medical history, any sort of surgery, things like that. So your investigations are then going to become important. Say we've ruled out all the classic GI issues, and we've taken a thorough history. We're going to be taking blood results, blood tests. Yeah, one of you just mentioned medication as well. Obviously, you're going to take a full medication history. That can be really important in what we discuss next. Yeah, your investigations are going to probably allude a little bit more. But again, you're just trying to think in that systematic manner when you see a patient. So this is yeah, hyperparathyroidism. So basically, you've got hyperparathyroidism isn't just one disease or isn't just caused by one thing. There are a number of, well, there's a summary of the disease itself. So you've got primary hyperparathyroidism. That's meant to say, which is with the parathyroid gland itself. So most of the time, this is caused by a singular parathyroid adenoma. Sometimes there are multiple adenomas. This is most commonly seen in your multiple endocrine neoplasia disorders, so MEN 1, 2A, and 4. 90% of people with MEN 1 present with symptoms of hyperparathyroidism. You've also then got nodular hyperplasia and carcinomas, which are very rare. It's around 1%, less than 1%. You also have secondary hyperparathyroidism. So basically what's happened is you've got reduced calcium chronically, and then this requires increased levels of PTH. So, that's where we talk about your CKD, malabsorption, celiac disease, things like that, and also vitamin D deficiency. So that's a good question. Someone's just asked, where do you find PTH results? Are they shown in TFTs? I actually think that you have to. I think it's a separate test. So to check serum PTH, I don't think it's within TFTs. I think that you will select that separately. That'll be something that might vary between hospitals though, so it'd be worthwhile checking. And then tertiary hyperparathyroidism. I always got a little bit confused by this, but basically what's happened is you've had a cause from secondary hyperparathyroidism. That's then resolved, but due to that chronic hyperparathyroidism, you continue to have hyperparathyroidism. So yeah. So often it's CKD patients, things like that are then resolved. Okay, so primary hyperparathyroidism. It's the autonomous production of PTH. It's usually that singular adenoma that we discussed. 1 in 800 have something like it. And so risk factors, it's 2 to 3 times more common in women, and age as well. So 90% of patients over the age of are over the age of 50. And as we've already discussed, it's found in MEN, where multiple adenomas are more common. Okay. So just a little bit of pathophysiology. So it's PTH secretion that's not suppressed by that high calcium level. Excess PTH leads to overstimulation of bone resorption, and that's what can cause the problems. So often these patients may be asymptomatic, so the hypercalcemia is often why patients present. These are the sorts of features that you get. There's that classic triad that people talk about, bones, stones, abdominal bones. That's actually not as common anymore. More often now it's sort of a generalized fatigue, depression, sort of more severely it's paresthesia, muscle cramps, but then also abdominal pain. So it's not a very specific thing, there's no, apart from the bone pain and renal stone, it's just quite a generalized picture, and that's why investigations are so important. And as it says there lower down, 50% are asymptomatic, so it's often an incidental finding in itself. There are those risk factors again. Okay, I'll send the slides out at the end as well. We've got a few extra notes underneath that you can look at. So your investigations, you're going to see that elevated PTH and a high serum calcium. Obviously in a normal feedback loop, you'd be expecting elevated PTH with a low calcium, and then you'd be hoping that would resolve itself. So obviously if it was the other way around, that would also be fine. But with them both high, that's where the problems arise. You can use ultrasound to locate an adenoma, and CT and MRI scans can be used. But basically, those three are used before surgery. So just to sort of find out a little bit more about the adenoma itself, where is it, which glands it on, those sorts of things. So the plain X-rays, you can plain X-ray the bones, basically trying to check for sort of your bone involvement with that. Because of the chronic PTH, that increased bone resorption, you start to worry a little bit about fractures and things. And then also a DEXA scan that can help assess disease progression, like it says. So you may come across something called FHH, familial hypocalciuric hypercalcemia. That basically is just a syndrome of low urinary calcium and high serum calcium. If you just go off quickly, I'll show you. That's okay. That's why. So it's not due to well, basically it's due to reduced sensitivity of the receptors to PTH, and so it continues to be produced, but it's not because of a central problem. It's due to PTH not being not being sensitive to the receptors, basically. Okay, management. So symptomatic, well, so because we discussed so many patients are asymptomatic, often they can just be monitored. But if they become symptomatic, or if there are any concerns, then a parathyroidectomy, surgical intervention is required. But you can also provide vitamin D supplementation. And if you're concerned about that sort of bone resorption and the levels that that's at, you'll think about bisphosphonates. Cinacalcet there increases the receptor sensitivity to calcium, and so in turn reduces your serum calcium and PTH. Okay. So do you have any questions about hyperparathyroidism? Okay. So this hypoparathyroid, I thought it would make sense just to go straight on to hypoparathyroidism. So obviously it's PTH deficiency that leads to hypocalcemia, hyperphosphatemia. And as we discussed in the quiz, it's most commonly caused by damage from thyroid surgery. Those total thyroidectomies cause 9% of patients to have hypocalcemia, which we will discuss the management of in a little bit. So we also have a pseudo hypoparathyroidism, where they look functionally they're hyperparathyroid, but it's due to parathyroid hormone resistance, whereas it's not an issue with the parathyroid gland itself. I also came across in my reading pseudo hyperparathyroidism, which I thought was hilarious, but we're not going to cover that because it just seemed very, very rare. Okay, so clinical features of hyperparathyroidism. Again, mostly asymptomatic, and it's because of the hypocalcemia, they might get muscle cramping, muscle stiffness, tetany. If you think about what calcium is used for in the muscles, it's for that, the presynaptic cleft. Your calcium causes, I've forgotten most of this. Your calcium is used at the presynaptic cleft to allow your acetylcholine as a neurotransmitter to be released. So you're going to have those problems with your muscles. Also, important to note that chronic issues. So obviously calcium voltage gated channels are found in the heart that can cause problems with your ventricular contractility. Visibly, you may see dry, brittle nails. So there are two clinical signs at the end. Shostak's sign. So what I saw was basically your facial nerve. If you tap over the ear, you get ipsilateral muscle twitching. So you might just see the corner of the mouth sort of moving, but it's only one corner, not the other. And then Trossard's sign. So these might become important in OSCEs if they ask you. But basically, when the pressure cuff is inflated to above systolic pressure, these sort of patients get their fingers start to sort of come together, and their wrist comes back a little bit. It seems like quite a subtle sign, but you do see it. There's some good videos that you can watch. So, just one thing to note as well. So basically, in your results in any investigations that we'll go through now, your albumin. So people with hypoalbuminemia, low albumin levels, the way that labs sort of detect calcium can give false negatives or give false readings of serum calcium. So that's just one thing to be wary of. But basically, you're going to see a hypercalcemia and a low PTH. Obviously, thinking about back to that normal loop, feedback loop, you would expect high PTH with a hypocalcemia. You're going to get an ECG just to make sure there's no prolonged QT intervals or arrhythmias that can occur from it. And you might see that your, so the reason why it's only the 25 hydroxyvitamin D that's there is basically more hospitals check bloods for that. You don't really check for your active form of vitamin D, but you might see that that's low. Hypomagnesemia is also common alongside hypoparathyroidism. Yeah. So then management's pretty simple. It's calcium replacement. If they're hypomagnesemia as well, so if they've got low magnesium, they're going to replace that. You can give PTH itself. You give it subcutaneously as an injection. I think most of the time you're going to try and replace it with the calcium though, just straight off. You can also, if they're vitamin D deficient, you can give like calcitriol, as we discussed earlier, with as a synthetic form. Okay, so case 2, same again. Sorry. So having read through that, 74-year-old female presented into A&E department after a fall at home. She's experiencing some back pain. So what sort of questions are you going to ask to a patient that's coming to A&E after a fall with back pain? Yeah, good. You're going to assess for neurological signs. You're also going to see any loss of consciousness. Good. Mechanism of the fall. Did anyone witness it, for example? That's a great question, Kate. Where did she fall from? From a height? You know, was it less than that? And that can be important in the disease we discussed. So yeah, good. Any sorts of symptoms beforehand? You know, what sort of state was she in beforehand? And then you're obviously going to be checking for any head injuries. Again, the full history, you know, past medical history. Yeah, you're querying metastatic bone cancers. Yeah, good. You're going to get, yeah, again, you're going to do your Socrates, your full history. I think one of the most important things is where did she fall from? So what we're discussing here is osteoporosis. And what you'll find is often they can be very, very small, subtle falls, sort of less than head height, that can cause a fracture depending on the sort of stage of the disease. So osteoporosis is reduced bone mass and abnormal bone architecture. So I'll show you the picture first. But basically, we'll go back to that slide. But basically, if you look in the bottom right of that photo, that's a normal bone matrices and microstructure. In osteoporosis, that's a lot less dense, and that's why you have the increased risk of fracture. It's just because it's so less dense. So basically, most of these patients are asymptomatic before they have a fracture. it's much more common in women, especially postmenopausal. That's because of estrogen. So estrogen deficiency increases the rate of bone loss because estrogen, so postmenopausal women overexpress rank ligand. I think I remember learning about rank ligand and sort of just ignoring it. But basically, RANKL causes osteoclast maturation, which then causes bone resorption. So if you're expressing loads and loads of RANKL, then you're going to get much higher osteoclast activity, and then that's going to cause increased bone resorption and that reduced bone mass that osteoporosis has. So your main risk, the main patients you'll see this in are elderly postmenopausal women, or as it says next, is that high dose chronic corticosteroid use. So think about those patients with the past medical history. So those patients with inflammatory diseases, have they had inflammatory bowel diseases that often need sort of high dose steroid use? Do they have rheumatoid arthritis that they've used steroids for years? Smoking is also a risk factor, but it is for most things, I guess. So in a similar way for postmenopausal women, hypogonadism, linked in with anorexia nervosa, that's why that's the cause as well. You get that lack of estrogen again, causing what we've already discussed, and then that reduced bone mass. Exercise is a huge way of improving sort of and regulating bone loss. You have lots of clever receptors in the bone, and they can sense the weight that they're put under, and that generates sort of remodeling and increased osteoblast activity. But again, calcium's huge as well. So that's your pathophysiology. We've shown the abnormal architecture. It's the increased osteoclast activity. And that's about the RANKL at the bottom. Okay, so these are some of your clinical features. As we said, most patients are asymptomatic until they have those fractures. So obviously then you have the symptoms from the fractures, your pain, tenderness, deformities, but after only, not necessarily a substantial amount of trauma, falls from less than head height, those sorts of things can cause these fractures. So your investigations, most blood tests are going to be normal. Quite interestingly, you might see some hypocalcemia. You might, but basically, and the sort of variations within that, but most of the time they can be normal. But the most important and diagnostic test is the DEXA scan. So that's the dual energy X-ray absorptiometry. So that's where you get your T-score. Obviously, so with osteoporosis, before that, to a lesser extent, you have osteopenia. That's your T-score from -1 to -2.5. And then after that, osteoporosis is from -2.5. Just T-score, if you can just remember that. I think I've seen past questions ask about that and things. But often it can just be an incidental finding on X-rays. With osteopenia, you can see sort of radiotranslucency. So in the marrow or in the center of the bone, sometimes instead of it being white, healthy bone, it looks just a little bit more sort of radio lucent. And that's something you can sometimes pick up on. So management, your conservative management, especially in OSCEs, don't forget to start with the easy stuff. If they smoke, stop. If they drink loads and don't have good dietary intake, stop, or increase that calcium intake. Increased exercise because of what we discussed earlier. And then we can start with the drug therapy. So if they've had that DEXA scan and it's less than 2.5, then they're going to start on a bisphosphonate. If they're within that osteopenia sort of range on the DEXA, then you can consider not starting one unless they're on corticosteroid use, which is why they've got that osteopenia. If they've had any fractures, you know, that symptomatic presentation, then they're probably going to start on a bisphosphonate. And there's some of the examples of bisphosphonates there. They inhibit bone resorption. Alendronic acid, risendronate, zoledronic acid, they're your main ones. So I think this is a common medical question as well, is when do you take bisphosphonates? They're very poorly absorbed, and they can cause things like esophagitis, and so basically what you'll see is that they're given in the morning, sort of 30 minutes before breakfast, so it's on an empty stomach, and then they sit upright for half an hour afterwards, just to try and help with that, the passage through the GI tract. Another sort of question that they like to ask, basically osteonecrosis of the jaw is a side effect. I don't think it's common, but it's quite a stark one, especially with the idea that obviously bisphosphonates are trying to prevent bone absorption. Osteonecrosis is of the jaw is one of those side effects. Again, management, you're going to be thinking about calcium, vitamin D if they need them. And at the end there, you've got denosumab, a monoclonal antibody that blocks that RANKL. And so, you know, that's useful in your postmenopausal women, things like that, where they've got that overexpression of RANKL. Okay. So, case 3. A 72-year-old attended his GP. He's experiencing increased fatigue, pain in his bones. He's a chronic alcoholic and housebound, so stays indoors without sunlight exposure. What are we going to be? So on examination here, we've got generalized tenderness of the long bones, some proximal muscle weakness. What are we going to be thinking about in our history, examination, investigations? Just put them in the chat. Yeah, again, Osteoporosis is obviously important. You can be thinking about the type of pain they're presenting with. Yeah, trauma. Again, we're thinking of all the same things in these histories. You know, is there any trauma? What were the preceding sort of issues? Is there anything that's been going on for a long time? Medication is important. Past medical history. Okay, we'll move on. So basically, that's a guy that's meant to be presenting with osteomalacia. Fortunately, it's less common now, particularly rickets. So both of these are the same pathophysiology. They're just slightly different syndromes in that rickets is some in children before, so it's because it's the enlargement of the growth plates and bone deformities. Osteomalacia is the same disease. It's just a syndrome in adults with defective bone mineralization. So most of the time, these are caused by vitamin D deficiencies. That's what I'm going to discuss. There are other causes, hypophosphatemia, there are acquired renal tubule defects, which affect phosphate reabsorption. They won't have vitamin D deficiency, so they might have slightly different investigation results, but they'll have the same syndrome. Okay, so the pathophysiology there. So as we already discussed earlier, the vitamin D increases your serum calcium levels by increasing that calcium absorption of the gut. It also stimulates some bone remodeling. So if you don't have that, you're going to have a reduced serum calcium level, which is then going to produce that PTH, and that's going to increase your bone resorption, just so you can normalize your calcium levels. So that increased bone resorption is where you start to get your fractures and things like that. If vitamin D deficiency is long enough, is prolonged, then you get so this isn't an acute disease. This has to go over a long time. For example, over the winter we get very little vitamin D intake, but most of us don't present with osteomalacia or rickets because during the summer we've built up enough stores. So this is a long-term thing. It's very rare in children now, but it does happen. You'll see some telltale signs though of that. So at least that hypocalcemia, hypophosphatemia, and then the demineralization of the skeleton as it tries to maintain that homeostasis in the blood. So here's just a small flow chart. You start with that reduced vitamin D level, the reduced calcium absorption, and then reduced serum calcium, and that causes your PTH secretion. Increases your bone resorption to try and normalize that. And then you get all those issues. So your causes are the lack of sunlight, poor diet. That's why alcoholics, elderly people that are sedentary, sort of indoors a lot, are more likely to get it. It's also more common in the elderly because of that reduced efficiency of the skin to convert the sunlight into vitamin D. So most of your patients are going to be old with osteomalacia. So as it says there, your inflammatory bowel conditions or your gastrectomies, sort of, there's quite a marked increase in osteomalacia from post gastrectomy patients. And then, as we alluded to earlier, your problems with your kidneys and the hydroxylation that obviously does to your active form of vitamin can cause osteodystrophy. So if you've not got if your kidneys are packed in and you can't hydroxylate your vitamin D properly, then you're going to have the reduced effects that causes. So anticonvulsants, so it's important to ask about medications. Anticonvulsants cause catabolism of vitamin D, which causes the problems. And then there are some more sort of rare interesting syndromes. Fanconi syndrome, it's just maybe one of note. That's meant to say excess, not express. Excess renal excretion of phosphate, glucose, amino acids, and bicarbonate. Basically, because of all that phosphate that's being removed, you start to get similar problems. So these are the clinical features. That photo in the bottom right is very common. That's your rickets, basically. Often I've seen questions linked with that photo, or one like it. But you're also going to see muscle hypertonia, delayed development, craniotapes, which I hadn't heard of before. But basically, that's where you can press on parts of the cranium and like a baby. Basically, your fontanelles will sort of cave to pressure. You also have bossing of the head, particularly frontal and parietal lobes, enlarged epiphyses of the radius, so you can sometimes do x-rays and that might show that. So with adults, though, osteomalacia is more of an insidious presentation. Often they're asymptomatic and then will present with fractures or mimic osteoporosis in different ways. So at an advanced stage, if you're getting fractures, there would be pain, muscle pain, and then general malaise and things, just because of the other functions that vitamin D has. Okay. So your investigation is going to do lots of blood tests. You're going to check calcium phosphate. They probably are going to be low, but a normal level doesn't rule this out. Your 25 hydroxyvitamin D level is going to be low. As I said earlier, that's the one that you're normally checking for in blood. Often you'll check the you won't check the dihydroxyvitamin D. So sometimes people will use a 24-hour urine calcium level. That'll be low. X-rays are often normal until advanced stage. So again, you're not going to see anything on X-ray or clear films. But if you do, then it may show those wide epiphyses in rickets and things like that. Osteopenia, like we said earlier, it's just that sort of look at radiotranslucency. So vitamin D is your, so these are some more investigations, sorry. In rickets, you're going to have a high PTH because obviously you've got that low serum calcium. The parathyroid gland is going to sense that and release more PTH. You're going to have a high serum ALP as well, but just consider what else can release that as well. So management, calcium and vitamin D, you're going to replace that, and apparently it shows a really quick and good clinical response. And you're going to just maintain that. If someone has got this because they live a sedentary lifestyle, they're staying indoors, you're going to try and encourage them to get outside. You're going to try and encourage them to eat more fish, milk, dietary intake as well. But obviously in the elderly patients that might not be possible for, you're going to stick to your vitamin D supplementation. Okay, so this is the last case. We've got a few more conditions after that I'm going to discuss, but they're not based around cases. So this one, 58-year-old gentleman presents to his GP complaining of some bone pain. He has noticed his favourite hat no longer fits, and so he's been a little bit stressed. He also seems to be hard of hearing. What do you think you'll be asking about in this patient? And if anyone has any questions, by the way, about anything I've discussed already, just ask. Yeah, good. Your Socrates, exactly. Your duration of symptoms, perfect. So the hearing, you know, in a 58-year-old person that's, you know, quite still relatively young, you're going to be wondering why that's happening. You're going to be asking, you know, have they been sort of exposed to loud noises, occupational, exactly, that's good. But I'll just move on. They've got Paget's disease. So that the reason why his hat's not fitting anymore is because of disorganized bone remodeling. So what Paget's is it's focused areas of bone resorption, formation, which sounds relatively normal, but then it's remodeled in a disorganized fashion. So it affects the axial skeleton mostly. That's the central part. And so, you know, small things like the hat not fitting, I mean, the chances of you picking up on that are relatively slim, but they're the sorts of things that can happen. And as we see there, age is a huge factor in it. It affects up to 8% of the population by the age of 85, and it's almost always diagnosed in over 40s. So that hearing loss occurs due to sclerosis of the temporal bone rather than compression, nerve compression. But as we'll see, I'll show you next, nerve compression can be a symptom. So your pathophysiology, increased osteoclast bone resorption, increased osteoblast activity, but then it's your disorganized bone remodeling that means that the architecture of it is abnormal, and so it doesn't possess the same mechanical strength. It also produces those sorts of bone depositions in different places. Your osteoclasts are the main driver of this. They're enlarged and high in number. It can also start to lead to osteoarthritis if you find it in subchondral bone. So again, it's mostly asymptomatic, but they may start to find that they've got some bone pain, deformity, or fractures. Bony overgrowths can occur, like we said. Peripheral nerve entrapment because of that. Cranial nerve defects. Family history is quite, well, in fact, very common in this. Often they'll have a family history of something like it. But then again, because it's asymptomatic, people will often say, no, I've not got any family history of that, because chances are that their family haven't experienced it or haven't seen the symptoms of it. So investigations, plain X-ray, I mean, this is quite drastic, but you might see some bone expansion because of that remodeling. Areas of radiotranslucency, if you see here, you see that difference in radiotranslucency. You've got some like darker radio opaque areas, but then generalized translucency as well. You're going to have, because of that osteoclast activity, you're going to have elevated serum ALP. And you can, in fact, get bone-specific ALP serum tests. But then the rest of you is also going to be normal. LFTs are important there because of ALP also being released by the liver. It's important to make sure that the bone is where this ALP is being produced. You can consider CTs sorted to identify disease advancement and stuff. So management, hopefully the asymptomatic, and you've picked it up incidentally. If not, then you can use bisphosphonates. The ones we've already discussed is zoledronic acid, alendronic acid, resendronate. So calcitonin is an iffy one. So basically calcitonin is found naturally in humans, but it has no clinical relevance of calcium levels. You would only use calcitonin, and I'm not entirely sure why you would use calcitonin, but BMJ best practice said you can. But obviously you're going to be trying to use your bisphosphonates first. You don't use bisphosphonates and calcitonin together though. If they've started to experience that hearing loss or any sort of nerve entrapment, things like that, you're going to be including your MDT. So physiotherapy, walking aids, hearing aids are also going to be important just to improve quality of life. So these are the more rare diseases. You'll see them on things like past medicine and you'll be like, what's that? Why am I getting 20 questions on osteogenesis imperfecta? So I thought I'd just cover it and a couple of others as well. So osteogenesis imperfecta, I do know what to say. Okay, so it's severe osteoporosis and multiple fractures in childhood. So you're going to see, this is very rare, but you're going to see people recurrently coming into A&E. It's patients that may be confused with non-accidental injury. Obviously, if you're concerned about non-accidental injury, you need to investigate that. But you can also consider that this might be something like osteogenesis imperfecta. In milder cases, they may have blue sclera. So that's a question I'm sure I've answered on past medicine. No family history, it's a dominant inheritance disease. So there are some of the mutations that it causes, your collagen genes that affect your collagen formation. You've got your bones are made up of collagen, and so obviously any mutations within the genes are going to affect that. And at the end, your management is basically MDT isn't definitely necessary. The amount of fractures they'll get, most of them probably need surgical reduction and fixation. Some of these patients do very, very poorly. So yeah, MDT is very important. Osteopetrosis, not to be confused with osteoporosis, is a rare inherited disease. So failure of osteoclast to function. So you can already start to think about what that might cause. But it does vary in sort of how it presents. So you present with failure to thrive, delayed dentition, cranial nerve palsies, blindness, anemia. I don't really know. I mean, I definitely don't think I knew about this for finals, but it's just there. So you might also hear of it being called Albus-Schoenberg disease in adults, which is slightly different, but presents with a similar sort of presentation. Okay, osteomyelitis. This is important clinically. It's a very, very severe disease, infection. You'll mostly see this with sort of on the wards. You'll see this in in orthopedic departments, people with external fixations in place. It's that really inflamed, maybe generating pus sort of area around the bone. If there's an external fixation in place, it's probably where that's protruding into the bone. It's a huge inflammatory response due to infection, most of the time caused by obviously your skin commensals like Staph aureus, but it can be caused by pseudomonas. Risk factors like diabetes, immunosuppression, those things that you would normally affect your normal ability to fight infection. It can cause local areas of osteonecrosis, and the way that you'll identify it is clinically you'll see that huge area of inflammation, and then if you want to follow that up with investigations, MRI is the imaging of choice. You'll be able to detect earlier changes on there. I mean, the only problem I can see as well is that if you have an external fixation in place, then obviously you're not going to be able to use an MRI unless the MRI is safe, and you'll use a CT. If you see obvious pus and things, take cultures, because your management is early recognition, then IV antibiotics for 2 weeks, and then oral for 4 weeks after that. Clinically, you're going to be reassessing this quite often during that period as well. If it is infected, you're going to have to resect that. And if that occurs, then you'll need orthopedic input for reconstruction if it's needed. So these are just some of the, just basically from the reading I was doing for it, these are some of the biochemical abnormalities that you might see in different bone disease. Here's that sort of, you can see that osteoporosis just has normal bloods most of the time. Paget's, you'll see that huge increase in ALP because of the increased osteoclast activity. Renal osteodystrophy, so from that CKD, you'll see the high increase in PTH because you've not got that active form of vitamin D, so you're going to have increased bone resorption to create that homeostasis that you'd normally have. In a similar way, the vitamin D deficiency, you'll see that huge increase in PTH, or not huge, but raised PTH to control the serum calcium levels. So I've just got another final quiz. I hope this one works. First time using Kahoot. Ah, there we go. Which one's that there? Yeah, okay. So if you want to join that, we're using that pin. Got one player, nice. Yeah, LOSHT for life, love that. Give you another few seconds. Okay. So these don't go into loads of depth. They're just going to try and give you a bit of an overall idea of what we've learned so far today. Okay. So I see that a lot of you there said, yeah, so basically the right answer is minus 1.5 to 2.5. Just be careful because it's osteopenia, slightly different T-scores. The rest, so it's a minus score as well with DEXA scan. Osteoporosis would have a minus T-score of less than equal or less than 2.5. The rest are just above or positive. So it's minus 1.5 to 2.5 for osteopenia, minus 2.5 for osteoporosis, which is where you'd be using your bisphosphonates and things for treatment of osteoporosis. And remember, your DEXA scans are your diagnostic tests for osteoporosis. Well done to MASH. Good. So it's that hyperparathyroidism, it's the abnormal feedback loop. The first answer that a few of you put, hypocalcemia and raised PTH, that's what you would want, because your PTH is going to act on your bones, increase that bone resorption to increase your serum calcium and normalizing it. Whereas the second answer, so the one that's right, the hypercalcemia and raised PTH, that's they're the results that you'll find with hyperparathyroidism. That will signify an abnormal feedback loop. With hypercalcemia, you'd be expecting your PTH levels to drop, because obviously your calcium levels are already low in the action that PTH has normally. Nice, well done, guys. Okay, good, well done. Everyone pretty much got that right. So yeah, your singular adenoma is correct there. Multiple adenomas you get with MEN more often. Carcinoma is incredibly rare, only less than 1% get that. Okay. Good. Okay, most of you got that right. That's good. So yeah, it's your reduced bone mass and abnormal bone architecture. Think back to that photo that we showed, where you saw the architecture and how thin it looked compared to, and sort of the reduced bone mass compared to normal bone. Your red answer is your osteomalacia and rickets. So you know that vitamin D deficiency causing your defective bone mineralization. You know, because basically your bone formation relies on calcium and phosphate that goes to the bone. So if you don't have your vitamin D, then that's going to be affected. So the blue one is Paget's disease. So that we discussed that earlier. That's the increased resorption and deposition, but it's all about that. What's the rate of bone resorption because of the high osteoclast activity, but then it's that disorganized bone remodeling which causes some of the symptoms as well. Postmenopausal fractures are what you can get with osteoporosis, but but obviously that's not a definition. So, okay, good. MASH back in the lead. All right, last question. Perfect. Well, I mean, this obviously, as we already discussed, a lot of patients present with other symptoms or more generalized symptoms. Bone stones, abdominal growths apparently is less common as it used to be. Don't forget, you know, most of these other symptoms I've written down are actual symptoms of hypercalcemia. So fatigue, memory loss, myalgia, your fractures aren't, but your paresthesia and muscle cramps are. Most patients with hyperparathyroidism are asymptomatic, with primary hyperparathyroidism at least. So yeah. Okay, who won? Well done. All right, nice match, well done. Okay, so Does anyone have any more questions? There's some of the sources I used if you want to have a look for stuff. Anything that you want clarifying or you have any more questions about, I'll try and answer. Like I said, I'll send you the slides. And if you can, please will you fill out that feedback form at the bottom? Be much appreciated. Okay, thanks guys. So most of the questions in exams interpreting results, it can be, and so I know, for example, on past medicine there are some, you know, if you go back to that slide, then so the reason why I've presented this in this way is because what I don't want, well, what I think might be more beneficial for you is if you can think about the basics behind these conditions. So instead of trying to learn, you know, these abnormalities that you'll find on serum tests, blood tests, if you can be presented with a load of results, and then sort of try and pick that apart and figure it out, then that'll probably be better. So, you know, if you see you've got a low serum calcium, and a really high and a low PTH, then that doesn't make sense. Then, you know, that's probably hypoparathyroidism. You know, trying to think back to those that normal feedback loop is important. The question, to answer your question though, possibly. So do we need to know normal ranges of blood results, for example? I'm pretty sure you don't. I think it would be really harsh if you knew, you know, even if they didn't have the ranges, then they'd say whether they were low or not. I mean, I couldn't tell you normal blood ranges. So, but I'd hope not. I'd hope they give you the ranges. Yeah. Okay. Any more questions? Sorry, it took a little bit longer. All right. I'll just, yeah, please fill out that form, but and I'll stick it in the chat as well, actually. Okay. All right, thanks guys.